Hello, I'm Dr. Shuvro H. Choudhury. I am the Director of Interventional Therapies at the Narayana Health Group, and today I'm going to talk to you a little bit about prostate trouble. Prostate trouble or benign hypertrophy of the prostate, whereby our prostate gland gets bigger as we get older, is a very common problem. I don't think any of us will escape it. To a smaller or to a greater extent, you will hear your friends, your family being involved by this disease called prostatic enlargement, for which they have got this trouble in passing urine. It can be from having to put a lot of more pressure to pass urine, to a sense of urgency or a little bit of dribbling at the time of urination, having to wake up at night 3 or 4 times, frequency of urination. These are the various symptoms that people get, a bit of burning during urination, and it's all because the bladder and the prostate, which sits at the bottom of the bladder, as it gets bigger, it blocks this tube called the urethra. It blocks it and compresses it so that the urine doesn't flow nicely. So the standard treatment for this, apart from some medications that you can give that can work for some time, is to remove part of the prostate gland around the urethra, so you create a larger channel, and that is called a TURP. Gone are the days where the whole prostate was removed. That's a long time ago, but nowadays this is a very nice procedure whereby a bigger channel is made. And of course there have been modifications of this technique, and there are various advancements in terms of laser, prostatic lift procedure, etc., whereby the procedure has been made more minimally invasive. Nevertheless, TURP is not without its problem. Apart from the fact, and this is often not discussed, is that there is a recurrence rate. I mean, once you have done a TURP, 20 to 30% of people will have recurrence of symptoms at about 5 years. But apart from that, it is an instrumentation across the urethra. So some risk of urethral stricture. The water that is used during the washing can cause some problem with the heart, etc. But the other thing in young people is this thing called retrograde ejaculation or erectile dysfunction, and these are problems that can happen regarding sex life, etc. So TURP is not without its problem. Now, medicine, as you know, always tries to move to more minimally invasive techniques. So one of these minimally invasive techniques is something called Prostatic Artery Embolization, or PAE, whereby what we do is we go through the arteries of the prostate gland, and we block the arteries off. So this is a process called embolization. So when you get an embolization, then what happens is that prostate shrinks because it's not got blood supply, so it becomes small and it relieves the pressure on the urethra. It's a wonderful technique. Usually patients are daycare or one-day admission. Of all the people that we treat, am I trying to say that everybody that walks in through the door with a prostate trouble should have this? No. But TURP is still a very good operation and still is the standard of care. But there are certain subgroups of patients, certainly. Everybody is eligible for a PAE, but the larger glands are better, of course, because the artery is bigger, so it is easier to treat. Younger people, because they cannot afford an erectile dysfunction, etc., so they are better with this group. Somebody is having bleeding, hematuria through the urine. TURP has one of the problems is bleeding. So if you actually do an embolization, it is going to reduce the bleeding too at the same time. Then there is another group. Anybody who's got a recurrent symptom after TURP, for example, or somebody who's on a long-term catheter and TURP is not being done because the patient has got other illnesses. I'll give you another very easy example. I work in a cardiology hospital, so a lot of people are on blood thinning medications because of their heart, aspirin, clopidogrel, and trying to do TURP on them is difficult because of the bleeding, whereas prostatic artery embolization, no problem. So there is a lot of patients in this subgroup that are very well suited to prostatic artery embolization and should consider it as an alternative to a more invasive transurethral TURP or transurethral resection of prostate. So the results are good. Up to 5 years, the results are almost equivalent. I am not trying to say that it is come to replace TURP, because we really do not know the really long-term results. But certainly at short term, including some very interesting studies whereby sham procedures were used instead of PAE, has shown that it is very good, certainly in the short term, as good as TURP. And but one thing, as a public, as a friend and family, you should be careful about choosing your team, because it is a very technical procedure. These are elderly people. You need to work these people up properly. We often do a CT angiogram, we do an MRI to rule out a cancer. Sometimes we'll do a urodynamic study because we want to make sure that we select out the patient well. We map out the anatomy, the arteries well before we do this procedure. And during the procedure, we have this thing called a cone beam CT. Inside our cath lab, we have a CT scan by which we can tell that the whole of the prostate gland has been correctly embolized. And it is really important to use this sort of techniques and kit, because this is a very technical procedure. So I just wanted to summarize by saying that today I wanted to talk to you about prostatic artery embolization for benign hypertrophy of prostate gland. It's a very common disease, and it is something that you should consider when it comes to your friends and family. Thank you.